Assalamu alaikum wa rahmatullahi wa barakatuhu, and you're very welcome to this recorded lecture, the first one for your course in obstetrics and gynecology. I have to say that I am very sorry that you guys have to start obstetrics and gynecology by e-learning, because obstetrics and gynecology is essentially a practical specialty. And your skills, your knowledge improves and grows with the practice that you get and that you are exposed to. So I always say at the beginning of every course that I have in obstetrics and gynecology, the way that you individually will benefit from the course is as much as you put in, you will also get out of this course. And therefore, I'm very sorry that this cannot apply to you at this moment. But we, Dr. Shema, Dr. Anwar, and I, we look at ways of getting you involved in the practical process of this course, and we hope that at the end of this time of university closure due to COVID-19, we will maybe see a time where you can catch up with all the practical stints that you have missed so far. So we do our best to, in the next few weeks, finish this theoretical input into your learning. Now, let us get to this lecture that we have today in front of us. Unfortunately, I also start this course with quite a dry lecture, and I'm sorry for that. I don't know, you probably do not know me well enough, but I like to ask questions within my lectures. It's really a way of making you think and follow the lecture and keep awake a little bit. So I'm also going to try that during this my recorded lectures, and I would like you to have a pen and paper next to you so that you can write down the answers to any questions I might pose during my lectures, and then just compare if you were kind of near the correct answer or very far away or spot on. Who knows? Okay, these are not challenging questions. Okay, so we're going to start today with a dry topic, as I said, but it's an important topic, and therefore we take our time for this lecture, and this is physiological changes in pregnancy. I have to move on the first slide always like this manually, and I apologize for that. Okay, so this lecture is supposed to make you appreciate the importance of the physiological changes a mother's body undergoes during pregnancy. We will look at the different systems to evaluate and appreciate their impact and understand how they might influence pathology in pregnancy. So first of all, I start with a question. What is the purpose of such physiological changes in the maternal body? Just have a quick think about it, what the purpose is. Write it down on your piece of paper. And what is their significance? So the purpose is really that they assist fetal survival and they prepare the body of the mother for labor. These are the kind of underlying purposes of the physiological changes in pregnancy. It is important to know about them so that you can evaluate and can appreciate them during pregnancy. So you do not think, for example, a mother with a white cell count of 11 has got an increased white cell count, but wait a minute, stop, this is normal. Secondly, you can anticipate and treat common conditions that occur in pregnancy, such as anemia, gestational diabetes, hypertension or hyperthyroidism, and others. So let us go through the system by system of physiological changes. the endocrine system. Let's start here and just take a minute with your pen and paper to write down which changes you know in the endocrine system. So the most important one possibly is in the pituitary gland, and you know that prolactin really goes up, the production of prolactin really goes up, and on the other hand you have a decrease in the FSH and LH. And I usually at this point ask the class kind of what is important in this, and of course because you wouldn't usually test prolactin in a pregnant woman because you anticipate this being very high. But you are right when you think about the pituitary gland and you connect it to the Sheehan syndrome. Although Sheehan syndrome is very rare, it is one of the things that every student seems to know about. And this is the fact that the pituitary gland grows a lot in pregnancy, but is supplied only by one artery, has one little artery to supply it by blood through its stem, and therefore when after birth you have a massive major PPH, it can come to ischemia in this pituitary gland as a result of the loss of blood pressure and therefore the inability to pump blood through this one artery, and the lack of collateral arteries makes it impossible for the pituitary gland to kind of keep its essential blood supply. And this ischemia then might show itself maybe 6 months maybe 6 months down the line after birth, when the period does not come back to the patient, when she comes to you and says, I've stopped breastfeeding 4 months ago, or so, or I couldn't breastfeed is actually what they usually say. I couldn't breastfeed. Therefore, I expected that my period recurs and comes back after, I don't know, 2-3 months, but now it's 6 months and I haven't seen my period yet. And this will make you think, has there something happened, such as the Sheehan syndrome? Then you will ask, how was your labor? How was your delivery? Have you had any major blood loss? And then she might tell you, yes, I needed 10 units of blood transfused, and this will give you an idea of what happened, and it might be Sheehan syndrome. Okay, so this is just at the told you at the side. The thyroid gland also sees some changes, but usually this does not affect the clinical situation so much of the patient. It only is that you have a natural increase in TSH, but not in T4 and T3, T4 and T3 concentrations. And this can reveal a subclinical hypothyroidism or iodine deficiency. When the TSH production needs to increase, it might not be able to do that because of this subclinical hypothyroidism. How about the adrenal gland and the pancreas? What changes do you know in them? Okay, so first of all, you have the cortisol, and you find that there's a natural increase in cortisol. This for storage and lipogenesis, to kind of supply the mother's body with enough kind of fat and storage for the baby. But you also have, and this is much more significant, an increase in peripheral insulin resistance. This comes to the fore at 26 to 27 weeks, but also prior to that, it can be, it starts slowly and starts to increase, but at 26 and 27 weeks in the third trimester, you find a massive decrease of peripheral insulin resistance. And this might then lead to gestational diabetes. Because of the increased insulin requirements to keep the glucose stable in this situation. So who's at risk of this problem happening to them? And you are right when you think about those patients who have first-degree relatives, usually parents, with type 2 diabetes. Those people are at higher risk of developing gestational diabetes, and those patients who maybe they have no relatives with, they develop gestational diabetes but have no relatives with type 2 diabetes. Also, just the fact that a woman developed gestational diabetes in their pregnancy puts her at an increased risk of developing type 2 diabetes later on in their lives. Okay, so this is also an important note to make. Not only will she be at higher risk of developing gestational diabetes in every following pregnancy, in every subsequent pregnancy, but also she will be at higher risk of developing type 2 diabetes later on in her life. And she should be informed of this because, as you know, such type 2 diabetes can be impacted by positive lifestyle changes, such as having regular exercise, at least 30 minutes, 5 times a day or more, 5 times a week or more, and also by a healthy diet and a healthy weight. The decrease of peripheral insulin resistance, or the increase of peripheral insulin resistance, also impacts those women that become pregnant when they already have type 1 or type 2 diabetes. It is especially relevant in type 1 diabetes, where in the first trimester the the glucose control remains very much the same as it is outside of pregnancy. In the second trimester, then it shifts slowly that they need to increase their insulin doses for better control. But in the third trimester, this is very stark. So sometimes women end up with taking 3 times as much insulin as they took before pregnancy. And this is not because they eat more. This is just simply because their peripheral insulin resistance has increased and they require more insulin for the same effect on their glucose, for the same control of their blood glucose. This is also true in type 2 diabetes, and therefore it is sometimes necessary later on in pregnancy. Maybe at first you could control the type 2 diabetes with metformin and diet and exercise, but later on in the third trimester, a change to insulin might become necessary for this reason. Okay, so this is a very important understanding of the physiological changes. Similarly, after birth, actually, this insulin resistance returns to normal almost immediately, so that after delivery, the patient should immediately revert to her original insulin doses that she took before pregnancy. Just a note on the side, often patients will have forgotten the insulin doses they took before pregnancy, and therefore it is important to either write them down yourself in her antenatal notes or ask the patient to write them down. Okay, so let us now talk about the cardiovascular system, and there are a real number of changes ongoing here in the cardiovascular system. Just write down the ones that you know of. Yeah, I'm going to start now. So in the first trimester, progesterone is very high and reduces the peripheral vascular resistance. And this causes postural hypertension in a number of women, and also causes the iconic faints that women sometimes have when they are pregnant. This, in the second trimester, the progesterone remains pretty much the same, but altogether the intravascular volume increases, and therefore the effect of the progesterone on the smooth muscles does not remain the same. Blood pressure drops. So initially, blood pressure is the same as before. So if women come for booking, for example, if 12 weeks, and you do their blood pressure, it is mostly a reflection of their normal blood pressure outside of pregnancy as well. But in the mid of the third trimester, so just to finish this this thought, if a patient comes in at 12 weeks and they have a high blood pressure, it might be an expression that they have chronic hypertension. So they become pregnant, but they have pre-existing hypertension. And this is seen in a raised booking blood pressure. However, in the third trimester, so initially the blood pressure even drops in normal pregnancy, but returns to normal in the third trimester and then remains normal throughout the pregnancy. However, pregnancy-induced hypertension, so that hypertension which is not due to pre-existing chronic hypertension, but which is actually happening because of the pregnancy, usually is found after 20 weeks, and this is also of course true for preeclampsia and eclampsia. Finally, the venous return to the inferior vena cava can be compromised in pregnancy, and this can happen especially when women lie supine in their third trimester, when they have quite a large gravid uterus in their abdomen. They lie supine. This gravid uterus can kind of compress the aorta slightly and compromise the venous return to the heart, and this might make women faint. Therefore, an important rule for pregnant women is, especially those in the third trimester, not to lie flat, but either to lie on a side or to lie in kind of semi-supine position, so that like 30-degree raised, so that this cannot happen, this compression of the aorta. Therefore, in any woman that is found collapsed in pregnancy, lying on her back, it is very important to kind of reposition her, to kind of relieve this pressure from the gravid uterus onto the aorta. Finally, we have some more changes within the cardiovascular system, and I hope that you were aware of some of them. First of all, we have an increase in angiotensin II, and this is causing some of the water retention that we see, and that expresses itself in edema, dependent edema, which is largely normal in pregnant women and usually resolves within 1 week or 2 after delivery spontaneously. Furthermore, it leads to an increase in plasma volume by 50%, or more, by 30 weeks gestation, and this enables or facilitates uterine blood flow, and also compensates for the loss of up to 500 mils of blood loss in a normal delivery is considered absolutely normal, and this is compensated by this larger fluid volume within the vascular system of the pregnant woman. It also increases the blood flow to the kidneys, the skin, and the mucosa of the mother, and this is why some mothers feel warmer than other people, and secondly also you feel sometimes the flushing and the erythema in the mother, so the pulmonary erythema, the flushing of the face in pregnant women more than in other women. The cardiac output increases by 30 to 50%, so this is a significant increase in cardiac output. And this is achieved by, first of all, an increase in heart rate and a more significant increase of stroke volume. And this starts in the first trimester, but really hits home around 20 weeks. Impaired cardiac function can present for the first time in pregnancy. It is therefore very important to always listen to to women's hearts when they first present in pregnancy, just in case they have a heart murmur or something that kind of suggests impaired cardiac function. Impaired cardiac function can typically present either in the first trimester when you have the postural hypertension, the drop in blood pressure, or in the third stage of labor after delivery of the placenta, when you have a sudden increase in the preload, and which in kind of subclinically impaired cardiac function can then become apparent because the heart cannot deal with the sudden increase in preload. It is important to know that the cardiovascular examination changes somewhat in pregnancy. You will often find a third heart murmur, or a third heart sound, I should say, not a proper murmur, a third heart sound. This is an expression of the hyperdynamic cardiovascular system in the pregnant woman, and is normal in pregnancy. You might also hear systolic flow murmurs due to the same reason, and these are also normal in pregnancy. However, if you find a diastolic murmur, they are never normal. Okay, diastolic murmurs are always potentially pathological. And you have to always then refer them to the cardiologist and see what the reason for your assessment was. The ECG changes are also, some ECG changes also occur and are actually normal, which is a left axis deviation, which is basically has been explained by the pregnant uterus pushing up the heart and therefore changing the axis of the ECG slightly. You might have slagging ST segments and an inversion or flattening of the T wave, and all of this is regarded normal in pregnancy. Sometimes women ask about exercise in pregnancy. Generally, exercise is always good in pregnancy. Throughout the pregnancy, it keeps women fit, it keeps them active, it keeps them well mentally as well, and it also prepares them for labor, which is a vigorous exercise for them. But it should be said to them that the exercise, they should not start with new vigorous exercise. So they should do exercise as they would usually do, which is normal exercise, but new vigorous exercise in pregnancy is not advised. So you should not start training for a marathon in pregnancy, because this takes away blood flow from the uterus to the skeletal muscles. Okay, so here now we are going to talk about the respiratory system, and just jot down what changes you know of, which come to your mind of changes in the respiratory system. Okay, let us go through them. You find that the tidal volume increases by 200 mils. But the respiratory rate remains the same, and this is a very important fact that you should take heed of, because if you have a pregnant patient who has a decrease in the respiratory rate or an increased respiratory rate, this is never due to the fact that she's pregnant. This is due to an underlying cause and might kind of be the first sign of some significant pathology that you have to uncover, such as a PE or pneumonia or other respiratory distress that she might face. So respiratory rate changes are not to be explained by the fact that she is pregnant. Oxygen consumption increases, which is not surprising, as they have to now supply the fetus and the placentofetal unit with oxygen as well. And you find sometimes a compensated respiratory alkalosis in the blood of those women. However, total lung capacity remains the same, but alveolar partial pressure of oxygen increases, so that the oxygen of the when this oxygen pressure increases, it makes it more possible to exploit and get more oxygen from the breath that women take when they are pregnant. And now I come to one dilemma of patients and obstetricians. This is shortness of breath. It's somehow a common symptom in pregnancy, and it can be the sign of a serious pathology such as PE, such as severe anemia. But it also and very frequently occurs without any underlying pathology. So it causes anxiety to patient and doctors. It is not well understood yet. So the bottom line of this is that you have to be aware shortness of breath can occur without underlying pathology, but you have to, before you can say there's no underlying pathology, you have to exclude important, significant causes of shortness of breath, such as PE or anemia, to be sure that this is not the cause of an obvious shortness of breath of a mother. Now we come to problems in the urinary tract, and if you come, I hope that we get the chance when you come and see patients at Emirati Hospital, you will see that this is a very common cause of problems in pregnancy, that urinary problems occur very frequently in pregnancy. This has many reasons. First of all, we go through the normal changes. You have an increase in renal blood flow and 50 to even 60% increase in glomerular filtration rate. As a result of the increase in blood volume, the urea, creatinine, and urate all decrease in the blood as opposed to normal values without pregnancy. You might have, as a result of the increased glomerular filtration rate, you might have more a mild glucosuria, which might be normal because you have more excretion of sugar as you have more filtration through the glomerula. You might get water retention and serum and the serum osmolality might decrease. Furthermore, by the increased progesterone, we talked about that in the beginning, you have a relaxation of the smooth muscles. This we already talked about, the impact of this effect in the cardiovascular system, but it also has an important impact on the urinary system. The relaxed smooth muscles also lead to a relaxation in the ureter and the bladder. And this might lead to an increased volume of residual urine in the bladder, but also the urethra. And of course, as you know, retention of urine within the urinary system increases the risk of UTI and pyelonephritis. And this combined with the general reduced immunity of the mother, you find an even higher risk of UTI and pyelonephritis. On top of that, you also find a 5% increase in the risk of asymptomatic bacteriuria. So you would think, oh, asymptomatic bacteria is not important, but in combination with the increased potential for residual urine within the urinary system, a significant number of bacteria in such residual urine might lead to infections more than commonly, more than outside of pregnancy. Therefore, in pregnancy, asymptomatic bacteriuria is important and needs to be treated. Occasionally, you find even hydronephrosis due to this relaxation of the smooth muscles. And you might find hydronephrosis, a mild to moderate hydronephrosis in pregnancy without any symptom, asymptomatic hydronephrosis. And after pregnancy, this hydronephrosis might again clear away. So, as a result of these changes in the smooth muscles and their impact on the urinary tract, you find a large number of women who present with UTI or even pyelonephritis in pregnancy, and they need usually aggressive treatment. The problem is that pyelonephritis is develops more easier in pregnancy, and pyelonephritis also is associated with the development of premature labor. So therefore, it is important and very important to treat UTI aggressively in pregnancy. Now let's talk about the hematological system, and I'm sure you are aware of some changes within this system. The most important change possibly is that the plasma volume increases, and this leads to hemodilution of the blood in pregnant women. This is something that women most women experience to some degree, but and even the hemoglobin is regarded as normal in women who are not pregnant when it is 11 or above. The WHO regards a hemoglobin of 10.5 in pregnancy as normal. So therefore, even the hemoglobin has been adjusted, or the normal hemoglobin has been adjusted for pregnancy. But here in Gaza, actually, it is an agreement that people regard the hemoglobin as normal if it is 10 or above. The reason for this is that the anemia rate, even with this cutoff here in Gaza, is 47% in pregnant women. So this is a very large a proportion of women who are anemic. Anemia is not taken very seriously, not by women and not by many clinicians here in Gaza, but it can have a major impact on the pregnancy, but more even on the mother. First of all, an anemic mother feels herself always tired and thinks she cannot cope with the life as well as a woman whose hemoglobin is normal. Secondly, it puts her at higher risk at delivery because, as I said before, you will always have blood loss at pregnancy, and 500 mils of blood loss, so 1 pint, 500 mils, is regarded as normal. But if you start with a hemoglobin of 12 and you lose 500 mils or even 1000 mils of blood at delivery, it doesn't change your situation or your health very much. But if you start with a hemoglobin of 9 and you lose 500 mils or 1000 mils, you are very soon in a dangerous situation and condition. And therefore, a normal hemoglobin is very important in pregnancy. It has also to be said that iron requirements rise to 60 milligrams of elemental iron or 300 milligrams of ferrous sulfate each day. So iron requirement rise in pregnancy. So this might exacerbate some nutritional deficiencies and increase iron deficiency anemia as well. At this stage, before I end here, at this stage, I also want to say that 72% of all maternal deaths that happened here in Gaza last year in 2019 were associated with women who also had anemia. So it appears that anemia puts women at extreme higher risk than those women are who do not have anemia, of even very severe consequences such as maternal death. Therefore, I really want to impose on you that you make clear to women it is important to take iron supplements. It is important to work on having a normal hemoglobin throughout their pregnancy. Another reason why, so you could think about 47% is really high for a rate for anemia, and this is despite the fact that antenatal clinics actually give free iron supplements to women. the fact is, it's not only the nutritional deficiency that they might face, it is also the fact that they have often lots of pregnancies. And we see this, that anemia occurs much more frequently in those women who had multiple pregnancies before, so in multi-gravid women as opposed to primary-gravid women. And this is because during a pregnancy, their iron stores get depleted. The fetus always takes what they can get from the mother. So the mother takes it from their iron stores. So after pregnancy, the hemoglobin might normalize to a certain degree, but the iron stores remain depleted, especially then if women do not have a sufficient birth spacing, so sufficient time between their pregnancies. So they need, the maternal body needs 1.5 to 2 years time between pregnancies so that they can get back to normal and replenish all of their iron stores as well as the hemoglobin. So frequent pregnancies and maybe lactation and then getting pregnant again in lactation is not good for maternal health and should be discouraged. So the other changes that we see in the hematological system are equally important, and this is an increase in clotting factors, which help to reduce bleeding at delivery. We see an increase in red cell mass, and these are the factors that lead to the susceptibility of pregnant women and women after delivery. In the first 6 weeks after delivery, their susceptibility to PE, so to DVT and PE, that puts them at very high risk of DVT and PE. And PE remains one of the most common causes of maternal mortality. Then we have a mild leukocytosis, which is not an expression of infection, but just an expression of pregnancy. Serum albumin is reduced and alkaline phosphatase increases due to placental production, but has no significance in this context. Okay, let us now look at metabolic changes or changes in the metabolic system, and these are somewhat controversial. The normal weight gain during pregnancy is about 12.5 kilogram, but only 5 kilogram is due to the placenta, the fetus, and the amniotic fluid. All the rest is due to the metabolic change women undergo and the increase in lipogenesis. Overall, energy expenditure falls, but energy requirements remain controversial. In the past, people used to say, you have to eat for 2 now, you're pregnant, but this is not true. Pregnant women can eat as they would or should eat as they would normally eat, a healthy diet and the same amount of diet as they used to have before pregnancy. Now we have several changes within the skin. Maybe you can kind of jot down some of them on your piece of paper. And these changes in the skin, they have very little obstetric relevance, so they have no pathological relevance, but they might be very important to patients, okay, because this is what they recognize. Maybe they are not aware of the residual urine in their urinary system, and they might not be aware of the increased leukocytes in their blood, but they might see the changes in their skin, and therefore this might be more relevant to them and should therefore be explained to patients. Okay, so one thing is they have increase in palmar erythema. You also find chloasma, which is a pigmentation of the face, the umbilicus, as well as the nipples. You might develop, patients might see stretch marks or stria gravidarum, and you might also find spider nevi on the abdomen. Stretch marks are especially unwelcome for women. It is actually, and they will ask you, how can they prevent stretch marks? I don't know if you have some idea to that topic, but I will give you the answer to that. You find some women who have had 6 children and you do not find one stretch mark on their abdomen, and other women, they have their first pregnancy, a normal sized baby, and their abdomen is full of stretch marks. The answer to the reason why some women have stretch marks and others not is the makeup of their collagen. And it is a genetic disposition that women have. So it doesn't matter how much stretch mark cream you go and buy in the pharmacy and you put on the abdomen, it will not change if you develop stretch marks or not. And you will see that the pharmacies here in Gaza, they are full of cream for stretch marks, but really they have no impact, and women should not be advised that this helps to prevent stretch marks, because it does not. The only thing that prevents some women from getting stretch marks are the makeup of their collagen, which they're reduced with, so a reduced disposition to develop stretch marks. Finally, we come to another important change the system, which is the musculoskeletal system, and this also is one that might worry the patient more than the obstetrician. Okay, so you find a laxity of the ligaments in the pelvis. Okay, the pelvic bones, and you find the estrogen. This is the estrogen effect in pregnancy that does that. You find a slight relaxation also of the joints of the pelvis, and this is to make room for the baby at birth, so that the baby can easily fit through the pelvic canal at birth. Okay, this is negotiated by the hormone relaxin as well as estrogen. In most women, they are not aware of these changes, but there's a small group of women who suffer terribly with these changes, and these are the women that develop pelvic girdle pain. Pelvic girdle pain is a pain that is in the past we used to call it symphysis pubis dysfunction, but really it is not limited only to the symphysis pubis. It is a pain that can be present in all of the joints or in any of the joints of the pelvis, and it is a pain that is not so much that develops during the pregnancy, so it's not present at the beginning of the pregnancy, and then usually coming in the 3rd trimester it gets worse and worse and worse, and it shows itself by women finding it very difficult to walk. So they might be pain-free sitting down, but when they get up to walk, this is very difficult for them, and this is due to a rubbing of the kind of relaxed joints, and with the relaxed ligaments, a rubbing of those joints together, and it can be very distressing. It is also a condition that gets worse with every pregnancy. So after delivery, it disappears, but with every pregnancy, it comes back, and it usually comes back earlier in the pregnancy, and it also comes back worse with every subsequent pregnancy. There are unfortunately there's no cure for this except delivery, and but it can be managed with input of the physiotherapist, of a kind of keen and motivated physiotherapists. They can help women to kind of move in such a way that is less distressing to their kind of pelvic girdle, and also they have some support belts and some support techniques that they can advise women to use to reduce such pain. Another problem that might occur later on in pregnancy is an exaggerated lumbar lordosis, which might lead to, which you can sometimes see in the typical gait of pregnant women in late pregnancy, but also it can sometimes translate into backache at the end of pregnancy, and also after delivery, this backache might persist for a while. But it can go away, usually with back exercises for the muscles of the back. With good physiotherapy, this can be resolved afterwards as well. Have you got any questions so far? Unfortunately, I cannot answer these questions at the moment, but I would like you to write them down on your piece of paper and keep them with you. And we can then, when we have our discussion forum online, we can discuss all these questions that come up. And I'll be happy to answer them at that point. So write them down and keep them with you in a list so we can deal with them in our discussion forum time. So in summary, there are multiple changes to promote fetal survival and preparing the mother's body for delivery that a mother undergoes when she's pregnant. It is very important to understand such changes and to know of such changes. First of all, so you do not declare anything to be abnormal when actually it is a normal finding in pregnancy. And secondly, that you can anticipate and treat common problems in pregnancy early on and effectively as well. And these are, for example, dilutional anemia. You know about increased iron requirements, so you can preempt this, leukocytosis, pelvic girdle pain, and others. At the end, I just want to give you a little overview of the blood result changes. It is important to know blood result changes so that you don't see a blood result and think, the albumin is reduced when this is actually normal in pregnancy, or you find urea is reduced when this is a normal finding in pregnancy. Okay, so hemoglobin falls, but should not be lower than 10.5. There's a mild leukocytosis. You find decrease in urea, creatinine. These can be profound decreases. So urea might only be 2.5 or something around that, or even only 2 in pregnancy. Creatinine, urate, albumin, bilirubin all go down, and alkaline phosphatase increases. Here you have a picture of all the differences in more detail. And you can, of course, if you're interested in, kind of copy this or photograph it for you if you want to keep it, but you might also find it in other context books. Okay, thank you very much for joining this first recorded lecture of your Obs and Gynae course. And with time, we will have more lectures, and some of them will hopefully not be as dry as this first one was. Thank you.